Everyone, welcome to researchmd.com. Another great topic today. We're going to teach you all about rheumatoid arthritis in under 9 minutes. Pertinent facts, all you have to know. But the repetition is the key, my friend. Keep watching it. There's no point in watching an hour and a half long videos and you cannot remember. But once watch the video 2 times, 3 times, write down the points and you'll be an expert on it, okay? Again, my name is Pramil Cheriyath. I'm a program director, internal medicine residency program, transitional residency program. I teach medical students, medical residents. I'm also director of research and assistant professor of medicine. So let's get into our topic. Rheumatoid arthritis, a chronic, autoimmune, inflammatory, synovial joint disorder characterized by symmetrical, the word is symmetrical, polyarticular arthritis, multiple joints, commonly affect the hand, wrist, and the feet. Smaller joints are more likely to be involved. And it can be like a multi-system involvement, okay? Epidemiology, more common in women, onset between 30 to 60 years, 1.5 million adults in the United States. Risk factors, age, older, increase. Sex, we talk about females. Genetic, there's like a lot of information coming out of genetic information. Smoking is predisposed. History of live birth, women who have never given birth may be increased risk. Obesity, like anything else, can increase the risk of developing RA. So if you look at the pathophysiology, you got like, this is the hypothesis, foreign antigen, and there's CD4 T cells, which kind of activation of B cells, T cells. On the left side, initiate hyperimmune response in the blood, formation of immune complex, then you have the pannus formation, then the rheumatoid arthritis. When you look, CD4 T cells also activate macrophages, then all these pro-inflammatory cytokines, TNF-alpha, IL-1B, INF, K, INF, and all of those kind of get activated, okay? Then you had activation of epithelial cells, which lead to increased expression of additional molecules. Inflammatory cells begin to accumulate, and all of this cause like the pannus formation in the classic, okay? So you talked about the causes, a lot of information coming about infectious agents also. Epstein-Barr virus is the one we have to watch out. Periodontal disease, even altered gastrointestinal microbiome, adverse life events, family history, all the genetic factors, HLA-DR, CTA4, CD40, all of this could be contributing it. Let's look at the signs and symptoms. One thing always to remember, morning stiffness lasting more than an hour, pain or aching in more than one joint, tenderness or swelling in more than one joint, same symptoms both sides. We said symmetrical, weight loss, fever, fatigue, and weakness, okay? Now, let's look at the extra-articular manifestation other than the joint, okay? Cutaneous manifestation, notably, you can see rheumatoid nodules and vasculitis. You can have accelerated atherosclerosis. So if you have a patient with rheumatoid arthritis come with a chest pain, take it very seriously, my friend. Pulmonary complication, you need to know about CAPLAN syndrome. Then you have ocular complication, episcleritis, scleroid, keratoconjunctivitis, Zika, ulcerative keratitis, all of that. Then you have hematological manifestation like anemia, leukopenia, neutropenia, you name it, everything is there, okay? And then you got FELTY syndrome. When you talk about the hematology, we'll come back to that. Neurological manifestation can have carpal tunnel syndrome or mononeuritic multiplex can have. So what are the things you have to know? Like for an exam purpose, you need to know CAPLAN syndrome. It's also known as rheumatoid pneumoconiosis. What's the combination of rheumatoid arthritis and pneumoconiosis? Inflammation and scarring in the leg. CAPLAN syndrome, if you're taking an exam, they will definitely ask you. FELTY syndrome also you need to know. Is the mnemonic is SANTA. S for splenomegaly, A for anemia, N is for neutropenia, T for thrombocytopenia, A for arthritis. So SANTA is the mnemonic for FELTY syndrome. Please remember that for your exam purpose. The other examination question when you talk about rheumatoid arthritis is going to be about pleural effusion, guaranteed. It's very specific finding, pleural effusion, when you do the fluid, okay, pleural fuel analysis. What are the classic findings? Glucose less than 30, pH less than 7.3, WBC less than 5,000, pleural fluid serum glucose ratio less than 0.5, okay? So remember the classic finding. Now, ACR, American College of Rheumatology, ULR, they are like, what is the European League against Rheumatism? They have their own criteria. So this given right there, greater than one joint with a definite clinical synovitis not explained by any other disease plus one of the following. Persons of long-standing disease, persons of greater than 2 typical periarticular erosion, score greater than 6 on the following criteria with the joint involvement. They have given score like 0 to 5, 1 median to large joint 0, 2 to 10 for median to large joint is 1, and 1 to 3 small joints 2, 4 to 10 small joints is 3, greater than 10 joints is like 5, more score, okay? And then autoantibody serology, rheumatoid factor, anti-CCP, and then acute phase reactant, CRP, and duration of symptoms less than 6 and greater than 6, you got 1 point. So based on all this, the criteria for definition. So diagnosis, what kind of test you can do rheumatoid factor, and you can do autoantibodies, which is or anti-CCP. So if you had to pick one thing, anti-CCP and rheumatoid factor together, okay? And you check for C-reactive protein, ESR, complete blood count, metabolic panel, and all that. Imaging, you do an X-ray, will come back joint aspiration if there is a fluid or large effusion. So first thing, you have to know about the blood test. We need to know the sensitivity and specificity of rheumatoid factor and the anti-CCP. So both of them together got the highest sensitivity and specificity, my friend. Both definitely, if you take an exam, they're going to ask. So if there's an exam, rheumatoid factor and anti-CCP together, pick that test. Sensitivity around 63 and 92% specificity. Much greater than each one. And then they will ask you about the X-ray finding, marginal erosion, joint space narrowing, and soft tissue swelling, diffuse cartilage loss, mild juxta-articular osteoporosis, cyst, degenerative disease, cortical thinning, okay? Those are the classic finding in the X-ray. You can do an ultrasound also. Good sensitivity and specificity, 73%, 78%. You can see the early inflammatory and soft tissue, synovitis, tenosynovitis, bursitis, early bone lesions. So sensitivity and specificity is also, I got a feeling in the future we may be using this. MRI got very high sensitivity and specificity. You can pick it up, the minute finding about the bone marrow edema, synovial hypertrophy, and fanus formation. Biopsy in arthrocentesis and medium large joint effusion may be both diagnostic and therapeutic. Very high sensitivity and specificity. So the treatment, you got the conventional DMARD, methotrexate, leufinamide or sulfasalazine, and then short-term low-dose corticosteroid, NSAID for pain control and symptom control. And then if moderate to high disease and progress, consider combination of non-biologic DMARD therapy or combination of conventional DMARD with a biologic DMARD or TNF inhibitor. That's the way to go. Non-TNF biological DMARD therapy. So the complications, you got osteoporosis, rheumatoid nodules, dry eyes and mouth, infection, then you can abnormal body composition, carpal tunnel syndrome, heart problem. A lot of people die with the heart disease, lung disease, and you can even cause like lymphoma. Thank you so much for watching. We'll be back with another presentation soon. Thank you.